Hello everyone and welcome to our module on maternal pregnancy complications. Let's start by talking about hyperemesis gravidum. So nausea with or without vomiting is very common in early pregnancy, and if the nausea and vomiting is mild, it's usually called morning sickness. But if it becomes severe, this is what is known as hyperemesis gravidum. Women who have severe nausea and vomiting in early pregnancy can develop hypovolemia with low blood pressure. They can also lose weight from not taking in enough calories. So when you're evaluating a woman in early pregnancy who has significant nausea and vomiting, usually what is done is to check the plasma electrolytes and a urinalysis. The reason you do this is because the vomiting can lead to alkalosis or hypokalemia, and if those things are present, they may need treatment. The urinalysis is also very helpful because if you identify ketones in the urine, then that means the woman is really not taking in enough calories, and that's why she's ketotic, and that suggests severe nausea and vomiting of pregnancy. For women who are volume depleted from hyperemesis gravidum, the treatment involves intravenous fluids to restore their volume status. It's super high yield for your boards to know that you want to make sure you give these women thiamine. There are rare cases of Wernicke's encephalopathy reported. This is a condition that develops from not taking in enough thiamine, and so if women are severely nutritionally depleted because of nausea and vomiting, they can develop thiamine deficiency, and they can develop Wernicke's encephalopathy, which presents as confusion. And then beyond the intravenous fluids and thiamine, you want to correct other deficiencies if they are present. So you want to correct things like magnesium, calcium, or phosphorus levels if these are low when you do electrolyte testing. The first step in treating hyperemesis gravidum is lifestyle changes. Women are advised to eat whenever they're hungry and avoid having an empty stomach, which can make the nausea and vomiting worse. Women are also advised to avoid any triggers for nausea and vomiting. Some common triggers are things like strong odors, or lying flat after eating. When medical treatment is prescribed, usually the first-line medication is doxylamine pyridoxine. This is a combination therapy that contains doxylamine, which is an antihistamine, as well as pyridoxine. Pyridoxine is vitamin B6 and it improves nausea through an unknown mechanism, and so this combination is usually the first-line medical intervention. In more severe cases, there are many other treatments that can be used to improve nausea and vomiting. Other antihistamines can be used besides doxylamine. Also things like dopamine agonists and ondansetron. These are all therapies that are used for nausea and vomiting outside of pregnancy, and they can also be used in severe cases of hyperemesis gravidum. Okay, moving on, let's talk about diabetes in pregnancy. So the thing you always want to remember about pregnancy is that it's an insulin-resistant state for the mother. In women who are pregnant, there's a decreased response to insulin, and this raises the serum blood sugar. This is evolutionary. The idea is to raise the blood sugar slightly so that there's more nutrition for the baby. But this has clinical implications. If women enter pregnancy already carrying a diagnosis of diabetes mellitus, their blood sugar control is going to be worsened by the pregnancy. And then there are some women for whom the rise in blood sugar is excessive, and they will meet diagnostic criteria for diabetes with onset during pregnancy, and when this happens, this is termed gestational diabetes. And even though the rise in blood sugar is evolutionary, if it's excessive, it can adversely affect the fetus. We'll talk about this in a minute. So it's important to identify and treat mothers who develop gestational diabetes. Screening is done for all women with serum glucose testing, and I talk in detail about how this is done in the video on prenatal care. In general, you need to diagnose and manage diabetes in pregnancy by measuring the serum glucose level. You can't check the urine for glucose because glycosuria is normal in pregnancy, and that's because of that normal rise in blood sugar that all mothers experience. Also, the hemoglobin A1C is of very limited use in pregnancy. You may know that when you measure the hemoglobin A1C, you are seeing a reflection of the blood sugar control over the last 3 months. And since things in pregnancy change so rapidly over 9 months, measuring the hemoglobin A1C is usually not helpful, and instead you have to check the serum glucose. When women develop diabetes during pregnancy, there are many potential adverse effects for both the mother and the baby. One of the biggest problems with diabetes in pregnancy is that when the blood sugar is high, the baby will grow more than normal. So it's very common for women who have diabetes in pregnancy to have babies that are large for gestational age and have macrosomia. When the baby is large for gestational age, this can lead to birth trauma. Shoulder dystocia, which I talk about in another video, is very common among babies born to mothers with diabetes. Also, because the baby gets large, in many cases a cesarean delivery is necessary. Diabetes also raises the risk for polyhydramnios and spontaneous abortion or stillbirth. It also increases the risk for preeclampsia. And then after the baby is born, when the placenta is taken away and the baby no longer has access to that high blood sugar from the diabetic mother, it's very easy for the baby to develop neonatal hypoglycemia, a common outcome in babies born to diabetic mothers. Congenital heart defects are common in babies born to mothers with diabetes. They develop in about 3 to 9% of babies. One of the most common congenital anomalies in babies born to diabetic mothers is transposition of the great arteries. But you can also see ventricular septal defects and things like truncus arteriosus, tricuspid atresia, or patent ductus arteriosus. A very rare but classic complication of maternal diabetes, and one that's high yield to know about for your boards, is the caudal regression syndrome, also known as sacral agenesis. This is a complication of the fetus classically associated with maternal diabetes. Usually it occurs in children born to insulin-dependent mothers. And it's called caudal regression or sacral agenesis because it involves incomplete development of the sacrum. In some cases, this syndrome can include sirenomelia, which is called the mermaid syndrome. This is when the legs are fused. Shown on the screen is a picture of a baby who has fusion of the legs. This is an example of the mermaid syndrome. On the right is a baby that has sacral agenesis, and you can see that the bones around the sacrum are poorly developed. Often when children develop sacral agenesis, they also develop a neural tube defect. The mainstay of treating gestational diabetes, which is diabetes with new onset during pregnancy, is through diet and exercise. Women are advised to control their carbohydrate intake so that they meet the caloric needs for the mother and the baby, but don't exceed those needs and take in excessive carbohydrates. Fingerstick glucose monitoring is usually done, and these are the targets at the bottom of the screen for fasting, 1 hour and 2 hour postprandial glucose. And usually medical therapy is initiated if more than 30% of the glucose values are above these threshold targets here. The mainstay of medical treatment is with insulin. In some cases, a minority of women are treated with metformin. This can be done in selected women in the 2nd or 3rd trimester. Some further management issues of gestational diabetes. First of all, there's a classification system for diabetes in pregnancy called White's classification system. Women are classified as type A1 by this system if they have diet-controlled gestational diabetes. Type A2 is insulin-controlled, and types B through D are women who had diabetes before they became pregnant, so-called pre-gestational diabetes. Induction is often considered for mothers who have diabetes in order to avoid macrosomia, so once the baby gets to term, induction will be considered because if you let the baby keep growing, macrosomia may occur. In addition, if these babies are large when they get to term, often a cesarean delivery is necessary. Now, usually the diabetes resolves postpartum. However, a mother who has gestational diabetes has an increased risk of developing type 2 diabetes mellitus after delivery. So these women always have a screening 2-hour glucose tolerance test at 6 to 12 weeks postpartum, and it's super high yield to know this for your boards. Acute fatty liver of pregnancy is a rare cause of acute liver failure that usually occurs in the 3rd trimester. For reasons that are poorly understood, in some women during the 3rd trimester, the hepatocytes of the liver become infiltrated with fat. This can progress to inflammation and eventually to acute liver failure. The classic presentation is persistent nausea and vomiting. Remember, nausea and vomiting in pregnancy is usually in the 1st trimester. If it develops in the 3rd trimester, acute fatty liver is one of the things to consider. Other features you can see depending on the degree of liver failure are things like jaundice or hepatic encephalopathy. The condition is identified by abnormal lab testing. The liver function test will be elevated, the bilirubin will be elevated, and the treatment is with immediate delivery plus supportive care. If the pregnancy progresses, the mother may develop fulminant liver failure, but if you deliver the baby, most cases recover after the baby has been delivered. Intrahepatic cholestasis of pregnancy is a cause of pruritus or itching due to elevated serum bile acids. This usually occurs in the second half, the later half of pregnancy, and the cause is unknown. Women will present with intractable itching, and the diagnosis can be made by measuring the serum total bile acids, which will be increased. You can also sometimes see mild abnormalities of the LFTs or the bilirubin level, but it's the increase in total bile acids together with pruritus that makes the diagnosis. The treatment is with ursodeoxycholic acid, which will reduce the bile acids in the plasma, and there is some risk to the baby in this condition, especially if the bile acids get very high. Potentially this can lead to fetal demise or preterm delivery. So once these women reach term, they're usually induced or have a cesarean section to deliver right away so that no adverse effects develop in the baby. It's rare, but appendicitis can occur in women when they are pregnant. It presents with the usual symptoms of abdominal pain, nausea, and vomiting. In patients who are not pregnant, the classic location for appendicitis pain is the right lower quadrant, but in pregnancy it can be in the right upper quadrant because of the fetus in the abdomen. The diagnosis is usually made by ultrasound, not CT scan like we use for non-pregnant patients. This is what it looks like on the screen here. It's relatively unimpressive unless you're used to looking at these things. In rare cases, if the ultrasound is non-diagnostic or inconclusive, you can do an MRI. And the treatment is with surgery, which can be done safely during pregnancy. Let's talk about urinary infections, which are very common in pregnancy. One of the main reasons for this is that progesterone levels, which are high in pregnancy, cause urinary stasis, and they decrease the flow of urine through the urinary system. They do this by causing relaxation of smooth muscle in the urinary tract, and so when there's less forward flow of urine, it makes it easier for bacteria to ascend in the urinary system and infect the bladder or the kidneys. So during pregnancy, it's common for women to develop a number of urinary infections ranging from asymptomatic bacteriuria all the way to cystitis and pyelonephritis. Just like with urinary infections outside of pregnancy, the most common bacteria is E. coli, but some of the other usual suspects for urinary infections can also cause infection in pregnancy, bacteria like Staph saprophyticus, group B strep, and Enterococcus. Because asymptomatic bacteriuria is so common in pregnancy, we always screen for this at the first prenatal visit by sending a urine culture. In women who have this condition, there's a high risk of developing pyelonephritis. There's also an increased risk of preterm birth. Bacterial infection of the genitourinary tract can lead to rupture of membranes and preterm birth. If the screening culture is positive, it's treated with antibiotics for 7 days. The choice of antibiotic drug is based on the bacteria sensitivity. Because we send a urine culture, we always know exactly which bacteria is causing the infection and which drugs it's sensitive to. You should also be aware that up to 30% of women do not clear the infection after 7 days of antibiotics, so a repeat culture to test for cure is almost always done. When women in pregnancy develop symptoms of acute cystitis like dysuria and frequency, they're treated with empiric antibiotics. There are a number of drugs that can be used in pregnancy. Some of the common drugs used are nitrofurantoin and fosfomycin, but there are other options. And then when the culture comes back and tells you exactly which bacteria is causing the infection and what drugs it's sensitive to, you can modify the antibiotic choice if needed. And then beyond cystitis, pyelonephritis occurs in about 2% of pregnancies, and it's one of the most common reasons that women who are pregnant require hospitalization during their pregnancy. The treatment is with IV fluids and parenteral, meaning intravenous broad-spectrum antibiotics. In general, beta-lactams work well in women who are pregnant with pyelonephritis, so usually these women are treated with either ceftriaxone, cefepime, or ampicillin gentamicin. And unfortunately, even after treatment, recurrence is common, and in some cases, women have to take daily suppressive antibiotics until delivery to avoid developing recurrent pyelonephritis. And then I'll finish with one slide on thyroid disease. So hyperthyroidism or hypothyroidism can complicate pregnancy, but the incidence of these disorders is not high enough for routine screening to be effective, so routine screening is not recommended with TSH measurement and thyroid function testing. You should be aware, however, and it's high yield to know this for your board exams, that hyperemesis gravidum is associated with high HCG levels, and this will stimulate the thyroid. HCG is capable of stimulating the thyroid gland just like TSH. So because of this, women who have hyperemesis gravidum, if you check their thyroid function tests, you will often see a low TSH and sometimes even a high T4. These findings are part of hyperemesis gravidum and they don't indicate a thyroid disorder. And because this happens, usually thyroid studies are not tested and are avoided in women who have hyperemesis gravidum. And that concludes our module on maternal pregnancy complications.